So I'm going to show you what a biofeedback assessment might look like when you have them on the commode and you're asking them to bear down. So I might ask the patient first to just bear down. I'm not going to give you any cues, and then they bear down. Let's say they have dyssynergia. It would probably look like this. So they got to go, and you see that flower close. So now if I do a rectal pelvic floor contraction, that will close the flower. I return back to rest. So obviously when you poop and you're bearing down, you do not want to be closing the flower, because if you close that flower and you're closing your rectum, if there is stool within the rectum, that's going to push the stool back up into the rectum. Now I find with some patients, they often think that this is productive, and then in their head it turns into pushing, because let's say there is a small piece of stool just sitting at the opening of the rectum, and then they suddenly do that squeeze, like around that piece of stool, it will actually drop a little piece of that stool into the toilet, because it's basically like you're cutting that piece of stool a little bit. The problem is they just sent a bunch of stool further back up in the rectum. So they kind of get this prolonged period on the toilet of waiting for stool to drop back down, trying to get it out, and they're not doing a very efficient way of evacuating their stool. Now, you can try different things in order to see if it helps them keep the flower open. So if I try and bear down, you can see I pretty much keep the flower open. I don't do the dyssynergia, which would be this. So now people might have poor force production, and that's a little bit trickier to tell, and that's when you need to kind of verify it manually. But when you take a look at the force production, those numbers that I showed you in the slide before, again, if you see kind of nothing happening, and again, just externally it seems like a weak push, which might look like this. And I definitely see that in some patients. You can verify that it might be the fact that they don't have good force production. Now, not having good force production can happen for a variety of reasons. So you can have a poor force production from a true muscle weakness. However, you can also have a poor force production if these pelvic floor muscles are in a shortened state. So when we talk about optimal force production, it's important to consider length-tension relationships. So I like to compare it to a bicep. So let's say my pelvic floor is my bicep. If my bicep is sitting here and it's in that more hyperactive state, and I try and go lengthen my bicep, it has nowhere to lengthen. So if you see someone has poor force production, the simple answer is not always to do rectal pelvic floor strengthening. What I usually would advise is if I sense that they have a hyperactive state, which you might have seen in the bar graph on someone, or I picked it up right away in my manual assessment, is we work on some manual therapy to these pelvic floor muscles. And the way we do that is internal and external myofascial release. Retest them then. That in itself might improve their force production. Versus if they feel like they have a truly weak pelvic floor, which you can generally tell in the manual assessment, then they might actually benefit from strengthening and then working on also, when I say strengthening, I mean strengthening of their pelvic floor, but also working on strengthening of their diaphragm and their abdominals to improve that force production.